trauma and mental health outcomes for Black children. In the next 20 minutes, I'll be talking about race-based trauma and its diagnosis, treatment, and impact on children of color in the U.S. I first want to point out that this concept of race-based trauma is not a formal clinical diagnosis in DSM-5, although the manifestation of this condition is closely linked to anxiety disorders, which are in DSM-5. However, often kids presenting with symptoms of race-based trauma are often diagnosed with mood disorders and behavioral disorders such as oppositional defiant disorder and conduct disorder. I will not be going into depth into these diagnoses because it is outside of the frame and scope of this presentation. But what I will do is take you through a journey of racial trauma by first giving an overview of anxiety and anxiety disorders as defined by DSM-5. Then I'll compare and contrast this topic with the construct of racial trauma and highlight the ways in which racial trauma manifests in children of color. I'll then present some negative outcomes for brown kiddos who have been impacted by race-based trauma and discuss ways in which this type of trauma is diagnosed, even though we know it is not a formal diagnosis. I will then address the impact of this lack of clinical diagnosis and how the symptoms of racial trauma are treated in the psychological and medical communities. Finally, I'll present some potential interventions to minimize the prevalence and impact of racial trauma on Black and brown children. So let's get started. So first, a caveat. I know that DSM-5 has an entire section of trauma and stress-related disorders, and this is great. However, the DSM-5 requires that to meet criteria for any of these diagnoses, a client must have been exposed to a traumatic or stressful event. Now, I'm emphasizing the word event, meaning a one-time occurrence that is life-threatening, as in post-traumatic stress disorder. And race-based trauma doesn't always meet that life-threatening event criteria. Likewise, because I will be addressing this construct with regard to Black children, DSM does list 2 trauma and stress-related disorders for children. Those are reactive attachment disorder and disinhibited social engagement disorder. Both of these diagnoses require that the child have experienced, quote, a pattern of extreme or insufficient care, and that's according to DSM. Race-based trauma doesn't meet these criteria either. So further, it's important to recognize that anxiety is often associated with worries about future events, whereas trauma can be viewed as a continued experience of past events or worry that the past event might reoccur. Based on these ideas, we can see how race-based trauma could fit into either category of anxiety or trauma. But I'm going to use an anxiety-based framework, not only because it's consistent with my own experience of racial discrimination, but also to highlight the fact that a Black person does not have to have an experience of a particular life-threatening racist event in order to exhibit worry and concern about future discriminatory events. So when most of us think of anxiety, we think of the feelings of being scared or nervous. The way we would feel if we had to give a presentation or when we have to take a high stakes test or when someone almost runs into us with their car. This activation of the sympathetic nervous system, which we have learned about most commonly referred to as the fight, flight, or freeze response, is pretty understandable by most of us. However, an anxiety disorder, as defined by DSM-5, is quite different. Broadly speaking, as I will not be going into depth into the various anxiety disorders, To receive a clinical diagnosis of anxiety disorder, there must be a few characteristics present. First, there must be excessive fear and anxiety and related behavioral disturbances, and that's according to DSM-5. Second, the fear and anxiety must last for a significant amount of time. So, for instance, at least 4 weeks for children with separation anxiety, or 6 months or more with someone with social anxiety disorder. So, we're not talking about a brief episode of worry about a presentation that you have to do. There's a big difference there. Third, there also must be the presence of psychosocial impairment. So this has to be really, the sense of anxiety has to really be affecting your life and the way that you work and engage with others. So let's talk a little bit more about what I mean when I use the term race-based trauma. Harrell in 2000 defines race-based stress as the race-based interactions that individuals of color have in their environment that are perceived by these Black and brown folks to tax resources and or threaten their well-being. Now, that is a big chunk of words to swallow, so let's make that definition a little bit more clear. Basically, what Harrell is saying is that race-based stress or trauma is in essence the physiological feelings of stress, the fight, flight, freeze response, experienced by Black people in their everyday environment. These stressful situations are unlike that typical life stressors that all Americans contend with, things like paying bills or doing presentations or getting a tax bill. But these physiological responses are exacerbated by their race and are in many cases a part of their experience just because of the color of their skin. Things like a Black man having a physical sensation of fear and anxiety when pulled over by law enforcement. Now, this type of stress taxes Black people's mental and emotional resources for sure. After all, it is super challenging to do anything productive when your fight, flight, or freeze response is always activated. But these situations, like the example of a traffic stop, also pose a perceived threat to well-being. So let me be clear, I am not saying that most traffic stops result in something dastardly. What I am saying is that if a Black man who watches enough national news and is exposed to enough incidents of police brutality like Rodney King in the 90s and George Floyd just last year, he might develop a very rational fear of being in situations that are similar and thus may physiologically respond in kind when presented with that same kind of situation. Let me go back. So let's talk about some common symptoms of race-based trauma. Yes, we know we're mostly talking about race-based trauma today in relation to anxiety, but these are some interesting bits of information that I did want to share. According to the National Child Traumatic Stress Network, young children can exhibit signs of trauma by having intense and ongoing emotional upset, sadness or anxiety, and behavioral changes, difficulty self-regulating, problems relating to others and forming attachments, and also having attentional and academic difficulties. Now, consider that children, since they are not independent adults that can live on their own, they spend an awful lot of time in environments in which they have to engage with others, in which they have to follow rules of authority, and in which, especially in school settings, they're expected to manage their emotions and focus. So if trauma and anxiety inhibits a child's ability to do these things well, then there are a whole host of consequences that these children experience that come from these symptoms. And we'll talk about those consequences next. So, some common consequences. Given the impact of trauma exposure on children's ability to be attentive, to self-regulate, and to relate to others, school can be a particularly challenging environment for Black children experiencing symptoms of racial trauma and anxiety. So, for example, African American children are more likely to be removed from the classroom for negative behaviors. Furthermore, Black kids receive suspension at higher rates than white kids, which have long-term detrimental effects on future academic achievement. I've already mentioned that due to the effects of racial trauma, Black children may have difficulty self-regulating, and that fact may impact the way in which school authority treat them. I noted above the statistics about Black students in suspension. It is also worth pointing out that students who receive out-of-school suspension are more likely to continue to be suspended, have academic and behavioral problems, drop out of school, and become involved in the criminal justice system. This is all according to research conducted by Fabello and colleagues. So as you can see, race-based trauma and the symptoms of anxiety that accompany it have long-lasting, substantial consequences for communities of color. Let's talk about diagnosis for a second. As far as diagnosing race-based trauma, the short answer is it is not diagnosed at all. As I mentioned earlier, the DSM-5 does have an entire classification of trauma and stress-related disorders. However, race-based trauma did not make the cut this time around. While race-based trauma is not a formal clinical diagnosis in DSM-5, there are measures that assess the symptoms of this construct. One of them is the Race-Based Traumatic Stress Symptom Scale, or the RBTSSS. Another measure is the Trauma Symptoms of Discrimination Scale. Those are two measures that we tend to use to address this construct. Let's talk a little bit about treatment. Now, while I didn't find any specific therapeutic approaches for race-based trauma in the literature, I will highlight 3 evidence-based modalities to treat children who have experienced trauma and anxiety. Okay. Muella and colleagues did a short study and found that in comparison to control group, youth who'd engaged in animal-assisted psychotherapy, or AAP, showed an improvement in 2 of the internalizing symptoms of trauma, depression, and sense of inadequacy. These teens also showed an increase in social skills post-treatment, in addition to an increase in positive attitudes towards residential staff and teachers at school. On the other hand, AAP did not show significant improvements in these teens' externalizing behaviors, which were things like verbal and physical aggression. Another emerging therapeutic modality in the trauma is the trauma resiliency model, or TRM. This is a body-based, bottom-up approach to healing trauma that accesses the client's experience of trauma first in the sensations of the body, and then makes meaning of the physical experience cognitively. I choose to present this psychotherapy as a potential treatment for children because often young kids do not possess the language to express their thoughts verbally, so a bottom-up approach might be more accessible to this group. And finally, since I've been framing race-based trauma from the framework of anxiety disorders, I will round out this piece on psychotherapeutic interventions by highlighting cognitive behavioral therapy, as it is an evidence-based modality that has been shown to improve symptoms of anxiety. Okay. So when we talk about anxiety in the way that our textbook has, we see that the physiology of the sympathetic nervous system activation is perfectly normal. It is an adaptive response to survival for humans. In other words, none of us would be here if we didn't have these systems in place. This response is normal so long as it is appropriate to the situation and it has not continuously been activated over a long period of time. Everything should be okay. However, from a race-based trauma perspective, a Black child may constantly be on high alert, assessing their environment for safety, while their body physically is prepared to fight, flee, or freeze. So let's talk about the structures of the brain for a bit that are activated with anxiety. So there's the amygdaloid complex. It's a little part of the brain located deep in the temporal lobes that runs several emotional processing circuits. These circuits help us assess environmental stimuli and evaluate cues for safety. Once it does this, then it can help us to orchestrate the appropriate response, either to fight or to freeze or to flight, right? We feel this activation in our bodies, and it can be measured there. Things like increased heart rate, blood pressure, slowed digestion, all places that our body is kind of activated to survive a threat. So neuroscientists have identified several neurotransmitters that they believe mediate anxiety, and I'll highlight three of them. The first is called the corticotropin releasing factor, or CRF. This neuropeptide controls the system that determines our automatic behavioral responses to stress. And the norepinephrine provides a mechanism to arouse and stimulate us to respond to fearful stimuli. Finally, GABA is known as the primary inhibitory neurotransmitter in our nervous system. Its job is to slow everything back down and help us to recover from an episode of fight, flight, or freeze. Okay, so how is race-based trauma treated currently? The short answer is that because there is no formal clinical diagnosis, there is no formal evidence-based treatment for it. But because we have been discussing this contract from an anxiety disorders framework, I'll talk about how we treat anxiety in children. In general, there are 5 types of anxiolytics, I think I'm pronouncing that right, that are used to treat anxiety. They are benzodiazepines, there are selective serotonin reuptake inhibitors, there are tricyclic antidepressants, and monoamine oxidase inhibitors, and buspirone. So for the purposes of this presentation, I will highlight the anxiety medications that are approved for PTSD, as well as the anxiety disorder, as well as anxiety, because even though we're talking about race-based trauma primarily as an anxiety disorder, it's still a trauma. So we're going to look at the trauma and the anxiety medications commonly prescribed. As you can see, SSRI like fluoxetine has been approved for the treatment of depression, generalized anxiety, and PTSD in children. Additionally, tricyclic antidepressants like tofranil and Aventil are prescribed for panic disorder, generalized anxiety disorder, and PTSD. So we have several kind of pharmaceuticals that we could use for folks who are experiencing symptoms of race-based trauma. To continue the discussion about psychopharmacological treatment in children, I did find some pretty significant disparities in prescribing practices. For instance, Allegra and colleagues found that white kids were at least 2 times more likely to receive psychotropic medications than non-white kids. Also, they noted that BIPOC kids have higher rates of non-completion of medication. This may play into the reasons that clinicians maybe don't prescribe these types of medications to brown kids as often, but the researchers did not speculate on this. They also found that brown children were more likely than white kids to receive inadequate psychopharmacological treatment. So not being prescribed the right medication or not being prescribed a therapeutic enough dose. So keep in mind that a client needs to have an accurate diagnosis before an appropriate medication can be prescribed. So some of this disparity might be because Black kids are more likely to receive an inaccurate diagnosis. So take, for instance, what I've been presenting today. Symptoms of race-based trauma are real, but because there is no clinical diagnosis for it, some Black kids may be diagnosed with ADHD or oppositional defiant disorder or conduct disorder, all of which might indicate much different medications than an anxiety medication. So how can we make this better? As family is the first social environment that most children experience, it is important to start there. Black parents and family members can provide the tools and emotional resources to assist their young children in coping with racial discrimination by engaging in racial socialization. Researchers Thomas and King coined the term racial socialization and described as described in Jenigan and Daniels' work. This type of socialization builds personal and group identity in such a way that brown kids develop a sense of pride in themselves and their racial identity. It also highlights the importance of intergroup kind of relating to members of one's community and intragroup having a sense of self relationships. Finally, racial socialization encompasses an aspect of critical consciousness, meaning an informal education of what it means to be a Black person in a socially and politically oppressive world. Having this kind of awareness enables youth to resist discrimination and have more positive psychological outcomes. To address how to improve psychopharmacological outcomes, first, I believe clinicians need to improve their accuracy of diagnosis for this population, perhaps starting with designating a diagnosis of race-based trauma or race-based stress. If this is done, then psychopharmacological treatment can be more targeted. Next, because it seems that BIPOC kids are less likely to take their medication, some community level psychoeducation may be warranted. Additionally, once a medication is prescribed, it's necessary that those clients can get reliable medication checks to refill and address prescriptions as needed. To improve this, we may need to look at removing barriers that often affect Black and Brown families, like reliable transportation and access to insurance that will cover the medication's cost. From a systems perspective of improving the outcomes of race-based trauma in children, there is much to do. First, address the mindset. There are lots of taboos in all communities, but there are certainly some taboos about mental health in the Black community. Things like Black folks don't go to therapy, or she's not crazy, she doesn't need therapy or medication, or to more systemic assumptions that those kids aren't suffering from mental issues, instead they're just bad kids with poor parenting. All of these taboos could begin to be addressed by consciousness raising or providing critical consciousness education that teaches key stakeholders in the community about the systemic causes of mental health issues. Another point of change could be in policy. So, for instance, we could advocate for policies that improve access to mental health care for Black children, not just for when a problem occurs, but more as a preventative measure. Similarly to how we go to the doctor for well visits to make sure that our physical body is in good shape, I think policy that allows for children to engage in mental health services as a checkup could reduce the amount of negative outcomes. Secondarily, we could advocate for policies that eliminate insurance barriers for this group to receive mental health care and pharmacological interventions. Finally, since children spend a good deal of their waking hours in school, it may be helpful to affect change in the schools. So, for instance, by training teachers on trauma-informed practices, this may also help eliminate the quote-unquote bad kid assumption that someone who is having problems regulating is a bad child just because they can't regulate. Also, we could begin to implement trauma-informed practices school-wide. Additionally, as politically tense a topic this is, I think it's important for schools to teach critical race theory in addition to including much more content from the perspectives and accomplishments of non-white groups in our public schools. In doing so, all children, including white children, get to bear witness to the humanity of all racial ethnic groups. And Black kids, of course, get to be validated for their lived experiences and feel a sense of pride in who they are at school. Okay, so that was a lot of information, but as with all topics, there is always more to learn and explore. So I have a few additional questions for further exploration should you choose to think about this later. First, it would be interesting to understand how race-based trauma affects Black parents' ability to be good parents to their kids. Also, I wonder what mediating factors there are that reduce the negative psychological impact of race-based trauma. And finally, I'm curious what interventions, either pharmacological or psychosocial, would improve this issue. Those are just my questions, but I welcome yours as well. And finally, please see my references below. Thank you for watching and listening.